I think I had taken one class on ECG, and we stopped it somewhere here, I think. Is it right?
हो सकता कैसे था भाई ना
So na?
हजुर
I think
यति थियो होला सर
we stopped it somewhere here, just like Malay.
हो सर
Okay. So whenever we do a ECG, this is one of the example of an ECG tracing paper, where you can see that there are 3 leads, 1, 2, 3, and AVR, AVL, AVF, and V1 to V6. These usually come in sequences like this: 1, 2, 3, AVR, AVL, AVF, then V1 to V6. These are called bipolar 1, 2, 3, and the lead which has got V on them are unipolar leads, and these are the chest leads. V1, V2, V3, V4, V5, V6 is chest leads, and these are the limb leads. So it starts with 1, 2, 3, then AVR, AVL, then we just go on describing the ECG from lead 1 to lead V6. There may be some in some ECG machines. There'll be long lead like this. Like in this, there's a long lead of 2, which we also call as a rhythm strip also. And we have to look at the name S6, and time is very important because ECG is a recording of a dynamic process. So time is very important. You may not have anything now, but after 6 hours, there may be a drastic change in the ECG. So time is very important to note. And later on, you see the speed of the ECG, that is 25 is normal. And the voltage of the limb leads as well as chest leads, such as in this is normal 10 millimeter per millivolt. And in chest also, this is 10 millimeter per millivolt. That means you can look at this sign also. So if you look at it here, then there will be 10 squares, small squares over here. So this says that this is a 10 milliequivalent per millivolt. This is normal. So after looking at all these parameters, then we compare with the previous ECG whether there are any changes or not, if previous ECGs are available. Okay, so while we go for the measurements, we look at the heart rate, whether that is atrial or ventricular or any different heart, if there's any difference in the heart rate. We look at the PR intervals, QRS duration, QT interval, and axis as well. And we'll go through these one by one in our class. And we can also look at the conduction abnormalities, like whether there is a sinoatrial block or AV blocks, like first, second, or third block, or interventricular blocks, such as Bunter-Branch block or fascicular blocks. So these can be also traced in ECG, and we'll see in the examples later on how they look like. We describe the waveform, and we look at particularly on the P waves, QRS complexes, then T waves, and sometimes there may be U wave, and we may have to describe this U wave as well. While we describe wave, we generally try to see whether it is wide, or tall, narrow, or something that looks funny, such as in atrial fibrillation or flutter. You will have different kinds of different type of P wave. It's not a normal P wave. So there may be difference in QRS complexes, whether there is a pathological Q wave or not, whether it is wide or not, whether they have got abnormal voltages. In the ST segment, whether there is an elevation, depression. In T wave also, we look at whether it's inverted or tall, or even we look at whether it's symmetrically inverted or symmetrically tall wave or not. because asymmetrical and symmetrical T-wave inversion or tall wave may have different interpretation, as we later will know what they mean. So before we go to all these waves, let us first of all try to know what is axis. Actually, axis is a vector of the ventricular activation. You may remember what is vector from your +2 knowledge, that it's a sum of two forces, okay, and is the vector. And we generally say that there is a normal axis or right axis or left axis or extreme right axis. And suppose there are two forces acting on this direction, and if it is acting on this direction, then the sum total of the movement of this force will be somewhere here in the 45 degrees. And this is what vector is. So this is what an axis for axis is in ECG. Generally, this is determined by the left ventricular activation, because left ventricle is more dominant. So usually the axis will be somewhere some authors even say that it's up to 100 plus 100 degrees. So this is a normal axis, and if we have left axis, that means it's between -30 to -90, and this is the right axis from +90 to 180 is the right axis deviation, and extreme right is from -90 to -80. And this is also called no man's land, and sometimes also called sometimes it's called extreme right axis as well. What does this mean is that, okay, if the axis is somewhere here, then we said right ventricular, there is a more dominance of right ventricle rather than left ventricle. Or if it is here, then it's more over of the left ventricular dominance than the right ventricular dominance. So it depends upon the dominant ventricle. If we can determine the axis by looking at the net QRS voltage, that means if you look at this QRS complex, there is an upward elevation and downward depression as well. So the net would be, suppose this is 1, 2, 3. Okay, there's a 3 squares over here, and there's a 2 square over here. So this is +3 -2 means it's +1. So it's a +1. This is net voltage is +1. So if and we look at these three, especially these two, lead 1 and AVF leads. If it is in the plus and AVF is also positive in net QRS complex, then we say that patient has got normal axis. If it is positive in lead 1, but negative if it is right axis deviation, then AVF will be positive and lead 1 will be negative. And in the extreme right axis, both will be negative. So if you want to look at what is the right axis very casually, then you look at these two leads and look at the net QRS voltage. So if it is positive, both are positive, then it's normal. Both are negative, then extreme right. If the lead 1 is positive, then it's left axis. And if AVF is positive, then it's a right axis deviation. But there's somewhat a little of flaw over here because this has got there's a a normal variant also from 0 to -30. To rule out this one, if you have a left axis deviation, like lead 1 is positive and AVF is negative, then always look at the lead 2. If lead 2 is positive, then it's a normal variant. And if it is lead 2 is also negative, then it's always a left axis deviation. So in left axis deviation, you look at the lead 1, lead 2, and if lead 2 is positive, then it's a normal variant. And if it is negative, then it's a lead 2. Why this is important is that normal axis doesn't only stop at 0 degrees, it goes beyond that up to -30. So if the patient has got ECG axis within 0 to -30, then this will be positive and negative, but lead 2 will always be positive. So to look at this one, this portion of the normal axis, we have to look at lead 2. To explain it more, let's look at this. So this is a +2, okay? Now lead 1 is +2, and AVF is +2. Here it is +2. So the degrees would be around 45 degrees, okay? And axis is normal, okay? Then if lead 1 is -2, so minus is over here, so -2, and AVF is +2, then where the resultant vector would be somewhere here. So it's -135, it's +135, sorry, +135, and this will be right axis. So lead 1 is negative and AVF axis. In this one, if lead 2 is positive, okay, here, lead 1 is positive, and AVF is negative. So 1, 2, 3, 4. So it would be somewhere here around 60 degrees, most probably. So it's -60. That means it's a left axis deviation. Now, if it is -2, okay, it would be 135 somewhere here, and this is the extreme right axis. So this is how it has come, how you look at it and how it has come. This is the explanation for that. Otherwise, it's very easy way to look at is thumb rule. If lead 1 is positive, that means the lead 1 is positive, then this one is up and this one is up. So both the thumbs up, then it's a right axis, so normal axis deviation. Okay, and if this one is left thumb is up, okay, right thumb is down, then as left thumb is up, so it's a left axis deviation. This is for left axis, this is left axis down and right thumb up, so this is a right axis deviation. So you can do it like this also. So in the rule of thumb, if lead 1 is positive, the thumbs up, and AVF is also thumbs up, then it's a normal axis. If right axis, then AVF will be up. That means right hand thumb will be up. Left hand thumb will be down, so it's a right axis. In left axis, left thumb will be up. In AVF, it's a down, so the right thumb is down, so left axis deviation. If both thumbs are down, then it's an extreme right axis. So this is rule of thumb. In heart rate, if it is regular, you can calculate in 2 ways. Whether it's first of all, look at whether it's a regular rhythm or irregular rhythm, and If it is a regular rhythm, it's very easy to calculate the heart rate. You divide 300 by number of large boxes between R waves, or 1500 divided by number of small boxes between the R wave. Suppose like this in the example is like in this one. Suppose this is there's a R wave from here to here. So there's 1, 2, 3 large boxes. Okay, so 300 divided by 3 is 100. So the heart rate would be 100. Now, if it takes same example and look at it here, then each large square has got 5 small squares. So 5, 10, and 15. So 1500 divided by 15 small square is also the result is same, 100. So heart rate is 100. In irregular rhythm, what you do is that you need a rhythm strip. Remember the rhythm strip? It's we have got here in this one. Sorry. This one. This is the rhythm strip. So it would be either 6 seconds or 10 seconds long. And we look at the rhythm strip, and this is 1 second. Okay, 1, 2, 3, 4, 5. 5 large square means 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, and 6 seconds. So in 6 seconds, count the number of R wave. 1, 2, 3, 4, 5, 6, 7. So in 60 seconds, what will be the number of R waves? It will be times 10, so 70. So the heart rate in this one is 70. Okay, you can do it in 10 also. Then if you count it in 10 seconds, then you multiply that one with 6. So in the irregular rhythms, you count the number of QRS complex in either 6 second rhythm strip or 10 seconds rhythm strip, and multiply by either 10 in 6 second strip, or by multiply by 6 in 10 seconds rhythm strip. Okay, in rhythm you look at whether there is whether the RR wave is coming regularly or not. This is not coming regularly. See this one, these are not coming regularly. So you look at whether it's regular or irregular, or whether P wave is present or not, and whether QRS is wide or narrow, and look at the relationship between P waves and QRS complex, because P waves should always precede QRS complex. And if it is not there, then there's some problem. Now, P wave denotes the atrial depolarization, and there are two halves: first half of P wave and second half of P wave. Usually, we consider first half of P wave as a right atrial activation, and second half of the P wave as a left atrial activation. Usually, the duration is 0.08 to 0.1 seconds, and amplitude is always less than 2.5 millimeter. And usually morphology is upright. Okay, most of the leads, but it's usually inverted in lead AVR. It's inverted in AVR, and it may be biphasic in lead V1, V2, and sometimes in AVL also. So most of the time it's upright, and the duration should not be more than 2.5 square from here and 2.5 square from this also. So to remember, it's around 2.5 from both sides. So this is upright, inverted, and biphasic. But there may be like fibrillatory waves, or flutter waves. This is found in atrial flutter, and this one is in atrial fibrillation. So as I told you, the first half is considered as a left atrial component, and second half as a left atrial component. And PI interval, it starts from the P to the starting of R wave or QRS complex. So it's this PR interval is this one, and this includes the AV nodal delay, and it's usually 0.12 to 0.2 seconds, and usually it's isoelectric. And in the QRS complex, this is usually comprised of Q, the negative deflection, R, positive deflection, and S is the second negative deflection. So this usually the Q wave is sometimes absent or sometimes very small, and there may be like here. I should show you this one. Okay, like this. There may be small q, r, there is no s. Okay, sometimes there is no q at all and only rs. And now there is a r, s, and second one again positive, which is we call as a r dash. And sometimes it may be just R only. So there are many varieties of QRS complexes. So if you have second positive wave, then you call that one as R dash, or second negative deflection, then it may be S dash, like and so on and so forth. So if it is tall, then we put this one in a capital letter. If it is a small, they're like R and small r like this, then we put this one as a small r. Okay, so there is a term called transition zone also, and this is usually lies in lead 3 and 4, where what we look at in transition zone is that in patient with like this, look at this ECG, the R wave is becoming taller and taller, okay, as it goes from V1 to V6, and S1 will become shallower and shallower. Okay, so by V4, V5, we won't have S wave at all. So this is the progression. The R wave becoming taller and taller, and S1 becoming shallower. Okay, so this is what the progression is, and we call this transition zone when it is R wave and S wave is more or less equal. It may not be equal, but more or less equals. In this one, V3 is more or less equal, so V3 is the transition zone. And sometimes it comes at R wave, V4 also. If it is not like that, suppose there is a persistence of S wave and deep S wave in V5 and V6, then we call that one as a poor progression of R wave. And that is usually seen in right ventricular hypertrophy or in corpuscular also. If you look at the QRS interval, then it starts from Q to end of the S, and it's generally below 0.1 seconds, from 0.06 to 0.1 seconds. And this, if it is more than this, then we call that one as a wide QRS complex. And in the ST segment, this is starts from the end of the S to the starting of the T wave. So this is usually isoelectric, and if it is above the isoelectric line, then we call that one as a ST segment elevation. And if it is below the isoelectric line, then we call that one as a ST segment depression. And the elevation and depression usually denotes it's whether there is ischemia or not. So there are few examples of ST segment elevation, like if it is concave upwards or convex upwards. This is a ST segment depression, which is horizontal or downsloping or upsloping. So I told you that there may be a difference in the ST segment elevation as well as depression the morphology. Usually, if it is concave upwards, then usually it denotes pericarditis, and convex upwards usually denotes the ischemia. So, ST segment horizontal depression is ischemia. Downward sloping or upward sloping denotes whether there is a left ventricular strain or not. Okay. T wave is which comes after this ST segment, and usually upright in most of the leads, but sometimes inverted in AVR. Most of the time in AVR and sometimes in V1. Normal T wave amplitude is in lymph leads it's less than 6, and in precordial leads it's less than 10 millimeter. And if we find that this is more than 6 and more than 10, then we call that one as a tall T wave. And another way to look at the amplitude of T wave is that if the T wave is more than 2/3 of the preceding QRS complex, then also we can say that that is a tall T wave. Okay. So this is upright T wave. This is peaked, inverted, nosed, and biphasic T waves. So these are various morphologies of T waves. This peak T wave this is normal. Okay, this is peak T wave maybe is because of hyperkalemia. The upright tall T wave maybe because of ischemia. Inverted T wave maybe because of ischemia, and so on. QT interval is the beginning of ventricular depolarization, and it ends up to the ventricular depolarization. So it includes all the events that takes place in the ventricle, and the QT interval is from this up to the end of the T wave. So this is QT interval, and QT interval usually depends upon the heart rate also. So you may sometimes have to correct QT interval, and you can do it with different formulas, but mostly used formula is called Bazit's formula, and that is QT interval is divided by square root of RR interval. So RR interval is from here to here. So you put a QT interval divided by square root of RR interval, then you will find that the corrected QT interval. U wave is it comes just after the T wave, and it's mostly prominent in V2 and V3 leads. And usually this is considered to be because of repolarization of Purkinje fibers, and it's usually upright, and most of the time it's absent, and it's around 1/4 of T wave. Height is around 1/4 of T wave, and it's generally denotes the repolarization of Purkinje fibers. Now, let's look at the example of this one. If you want to calculate heart rate over here, then you look at the big squares. Suppose this one is 1, 2, 3, 30, sorry, 15. 15. So it's a little lesser than 100 heart rate, because you divide 1500 by 17, then it would come around 90 plus. So heart rate is 90. Okay, so it's regular. If you look at the axis, then this is positive. The negative is small, so the net QRS voltage would be positive, and in AVF also it is positive. So this one is positive, this one is positive, means it's a normal axis deviation. And if you look at the P waves, so P wave is fine, upright, okay. and your QRS complex is also looks fine. There's no broadening of QRS complex. If you look at the duration, 1, 2, 3. So 3 means it's not wide as well, and then you go to the segments now. Okay, PR interval, QT intervals, and then you describe T wave. There is no U wave, and look at the progression of R wave also. Okay? The R wave is gradually increasing in amplitude, and the S wave is decreasing. So there's no S wave over here. So it's a normal progression of R wave with a transition zone at V3. So this is a normal ECG. Okay, so this is what we look at in rate. Okay, this is 5, 10, 15, 20. Okay, so 1, 2, 3, 4. So 300 divided by 4, it should come around 72 or 75, something like that. Okay. So it's normal. Rhythm is also normal. P wave looks normal and upright. PR interval is also normal. Okay, from here to here. So this is a sinus rhythm. Now look at this. This is all are normal, but 1, 2, 3, 4, 5, 6. 6. Let's put it as a 6. Then 300 divided by 6 is 50. So it's slow. So it's a sinus bradycardia because all others are normal. P wave is followed by QRS interval. It's regular. So it's a sinus rhythm, but it's bradycardia. This is sinus tachycardia. P wave, there is a normal shaped QRS complex, T wave, and rhythm is normal, regular. So this is a sinus because the heart rate is suppose let's take it over here 5 and 10. So this is 150. The heart rate is 150. So this is sinus tachycardia. In atrial fibrillation, this is a rapid erratic electric discharge. Comes from the multiple ectopic foci of the atrium. Rate would be atrial rate would be more than 350, and ventricular may be slow or fast depending upon how it has transmitted to the ventricle. The rhythm will be irregular. There will be no true P wave, but chaotic atrial activity. There won't be PR interval. QRS complexes would be normal. So this is what it looks like. This is the fibrillatory wave that we call. This is irregular. Sometimes it's nearer and sometimes wider. So it's irregular, and QRS complex is normal. It's normal. So this is atrial fibrillation. Okay, and in flutter, this would be replaced by a flutter wave. Okay, and the actual rate would be a little bit lesser, around 250 to 350. Rhythm will be usually regular, but sometimes may be variable also. And QRS complex will always be normal. This is atrial flutter. And premature complex ventricular complexes are usually we have got different names for that. Like this is what the extra beat of the heart from the ventricle causes this complex, and it may be uniform or multiforms. Uniform is that like the every ventricular complexes looks same, then it's a uniform. If it's different, then it's multiform. Uniform means it has come from same site, and multiform means from different positions. And it will always be followed by a compensatory pause. Okay, yeah, and the rate depends upon the underlying ventricular rhythm, and rhythm will be irregular, whenever PVC occurs, and there won't be any association with the PVC, with the P wave or PR interval. QRS will be very wide and bizarre. So this is the normal QRS and normal beat, but this one is a PVC, that is premature ventricular contraction. So this is the PVC. Okay, so uniform, this is uniform, okay, but this is multiform. See, this one is different of morphology, and this one is different morphology. So this is a multiform. Again, it can be considered as a like bisemini, trisemini, quadrisemini, okay, and couplets, something like that. If it comes in alternate, like one normal, one PVC, another normal PVC, then we call that one as a bisemini. If it comes after every two, then it's trisemini. If it comes in every 3 bits, normal bits, and then PVC, then it's a quadrisemini. If 2 comes together, then it's a couplet. If 3 comes together, 1, 2, 3 PVCs, they're normal, and 3 PVCs, they're normal, then we call that the triplets. And if 4 comes together, then it's a quadruplets. And if 5 comes, then it's a ventricular tachycardia. So if there are long run of PVCs together, then we call that one as a ventricular tachycardia. So rate would be around 100 to 250. There may not be association with the QRS and P wave. PR interval will be none, the wide, and there will be AV dissociation. That means there will be no relation between P wave and V waves. Okay. So this is somewhat a very life-threatening kind of ventricular tachycardia. Ventricular fibrillation is very chaotic, and it would be like a drawing line. There won't be any PA, PR interval, QRS will be none. Rate cannot be determined, and it's a chaotic, and it's a life-threatening emergency of patient. In AV blocks, the first degree block, second degree, and third degree blocks. In first degree block, what happens is that only the QRS will be prolonged. So this is a P wave, and this is PR interval. So the PR interval is more than 0.2 seconds. So this is a first degree heart block. In second degree heart block, there are 2 kinds of second degree heart block. You know that, working back 1 or MOBIS 1 or MOBIS 2. And in the MOBIS 1, the PR interval increases gradually, and then there will be a block. So this is like this. So this here, if you look at PR interval, is normal, but in this one it has increased a little, and then there is no transmission into the ventricle. So there is a P wave, but no QRS complex. So again, it comes again normal, a little bit longer, and there is no QRS complex. Okay. In type 2, you know that there will be 1:1 or 1:2, 2:1, 3:1 blocks like this. So there is 2 and 2, 1, 2. There is a block. Okay, so it will go on like that. In third degree heart block, that is complete heart block. So there will be complete dissociation of atrial and ventricular electrical activity. Atria will have its own rhythm, and ventricles will have own rhythm. And the cure, it will be like this. See? The PR interval, PP will be coming regularly, okay, at its own pace. And QRS, this is the ventricular activity, and it is coming in its own pace again, but there is no association between P or with the P wave and QRS complex. So this should be regular in its own, and P will also come in its own regular um, pace. In the bundle branch blocks, you will have a notched QRS complexes, and the QRS will be wider with notched appearances, but P wave will be normal, rhythm will be regular, PR interval will be normal, and it will be something like this. Okay, this is like a notched one. So the other as usually normal. The P wave is normal, PR interval is normal, but this one will be broader, which will be more than 0.1 seconds. And if it is more than 0.12, then we call it as a complete bundle branch block. If it is between 0.1 to 0.12, then it's called as an incomplete bundle branch block. So in left bundle branch block, you will have this kind of morphology with broad notched QRS complex with T-wave inversion in the V5, V6. Okay, so as this is a left-sided lead, so you find that one in the left side with deep S wave in the V1. In right bundle branch block, it will be different, just opposite. Like you'll have a notched one with a T wave inversion in V1, V2, but deep S wave in the V6, V5. So it's just opposite of left bundle branch block and right bundle block. Okay. In myocardial infarction, we look at 2 or 3 things like ischemia and infarction is what we want to differentiate, and there will be evolution of acute MI in a very proper way. Like this is a very acute, very early period where only the T wave is gradually becoming taller and taller. Okay, like this. And after this, you will have a ST segment elevation as well. So T wave, tall T wave, ST segment elevation, then there will be appearance of Q wave, and there will still be ST segment elevation, but T wave will become inverted. And later on, the Q wave, ST will come to its own position, but there will be T wave inversion, and after complete resolution, Q wave will always be present. There won't be any ST segment elevation, and T wave will be normal. So with appearance of Q wave like this, it's a clue that this patient may have had MI in past. So the few examples of myocardial infarction. In inferior wall myocardial infarction, you will have changes of this like ST segment elevation, Q wave, T wave, tall T wave, Q wave in lead 2, lead 3, and AVF, because these are the inferior leads. And you'll have reciprocal changes of ST segment depression with T wave inversion in other leads, especially in V1 to V5. Okay. This is an anterior lateral wall MI where you'll have a ST segment elevation with T wave. Okay, here. So in the V6, V5, V4, and V3. Yeah, so in a hypertrophy, we can also tell by looking at the ECG whether there is a right ventricular hypertrophy or left ventricular hypertrophy or left atrial hypertrophy or right atrial hypertrophy. So in atrial hypertrophy, if you look at it, this is the normal one. We said it will be more or less equal, not more than 2.5, and in duration also it's not more than 2.5. In if the patient has got like right atrial or left atrial or right atrial hypertrophy, then we can see that like the there will be a notch and broadening of P wave, notched and broadening of P wave, and somewhat like M-shaped. And we call that one as a pre-mitrally, and this is found in left atrial enlargement. In right atrial enlargement, you'll have a tall P wave. It will be more than this tall one. And we call that one as a P pulmonale, and that was found in right atrial hypertrophy. So in atrial hypertrophy, you'll have P pulmonale, and left atrial hypertrophy, you'll have P mitrale. In ventricular hypertrophy also can be diagnosed with the help of ECG, and there you can, in right ventricular hypertrophy, there will be right axis deviation. R will be larger than S wave in V1, and S wave will be deeper than R wave in V6. In left ventricular hypertrophy, R wave will be more than 13 millimeter in AVL, and if you add S wave of V6, R wave of V5 and V6, and S wave of V1 and V2, then it should be more than 35 millimeters. And generally, they will have left axis deviation in AVF. As I told you, the R will be more than S in V1. See, R is more than S1, and S is deeper than R in V6. So S is deeper than R wave in V6. So we call this one as a port progression also, because as I told you, in left ventricular hypertrophy. Okay, so and look at it here. This is negative, okay, and this is positive. Okay, so you have got a right axis deviation. In AVF it's positive, and V1 it's negative. So you have got a right thumb up, and that is right axis. In LVH, okay, AVL R wave will be more than 13. Okay, and now if you count the R wave of V1, V6, and S wave of V1, okay, like 5, 10, 15, 20, this is around 24, okay, and here it's 5, 10, 15, 20. So suppose 20 plus 24 is 40, more than 35, so it's a left ventricular hypertrophy. And here, look at it here. This is positive, this is negative. Okay, so this is positive and this is negative. And as I told you, the negative, this one is right thumb is up and left thumb is down. So it's a right axis. But once you have a left axis deviation, you look at the lead 3. So in in from exam point of view also. So in hypokalemia, you'll have flattening or inversion of T wave, increased prominence of U wave, and there will be slight depression of ST segment, prolongation of PR interval, prolongation of QT interval, and there will be any kind of arrhythmias, tachyarrhythmias, or premature beats. So in hypokalemia, you will have the flattening like these, see, flattening and inversion of T wave. Okay, see, the T wave is becomes smaller. Okay, and sometimes you have U wave. Here it is U wave. This one is U wave. Okay, and in and there will be a ST segment decrease, amplitude will be, P wave will be more. In hyperkalemia, there will be a peaking of T wave, prolongation of QR interval, prolongation of PR interval, shortening of QTC interval, flattening or loss of P wave, and arrhythmias. This is what tenting and tall T wave is of hyperkalemia. T wave flattening over here, okay, and becoming inverse. This one is peaking up, okay, and there may be a widening prolongation of the QT interval in this one. So these two are completely opposite of one of each other. There is something like pacing also, and if you have a patient who has pacemaker, then you will have an artifact like this in the ECG, and with that you can say that okay, this patient has got a pacemaker. So this is pacing artifact. So this is what ECG is. Now, to end it, I'd say that ECG has to be read in a very comprehensive way. And if you look at one thing, then it may not be a true finding. And all the ECG finding has to be put together, and then only you will be able to diagnose it. It's something like blind person describing an elephant. If you describe, this story about blind people describing a elephant, someone feels the tail and says that okay, elephant is like a rope. Sometimes some blind man can just feel the body of the elephant and say that okay, it's like a wall, or this may describe it in different way, okay, by feeling this trunk. So but this is only a partly true, okay, because they didn't feel all the parts of the elephant and just described it what he or she felt. So the ECG should also not be like that. Okay, you should look at the elephant as a whole, as if ECG as a whole, and then only you describe it. Okay, so this is what ECG is, and actually ECG is a little bit difficult, and you need a great practice. Otherwise, you'll just forget it what you have studied now in 2 days, and then your knowledge on ECG will be zero again. So you have to practice ECG, and there is a one saying that ECG is like a double-blind study. It's double. What do you know? What is double-blind study? In double-blind study, the treating physician and the patient won't be knowing what they are doing, okay, in research. So they call that one as a double-blind study, and it's like we call ECG. If ECG is being interpreted by two orthopedic surgeons, then we call that one as a double-blind study, because even though they have studied the ECG in MBBS time or in their medical officer time, but they have left looking at the ECG for a long time. So actually they will forget something on ECG, and they won't be able to interpret all that of ECG. So if the two orthopedic surgeon is looking at the ECG and trying to interpret it, then it would be like a double-blind study. So it should not be like that for you. So keep on looking at the ECG, try to interpret it and see, and good luck. Thank you.